right, well, we might get underway, I think. Good morning, everybody. Thank you so much for joining us. I can see we've got about 15 people online at the moment, so that's wonderful. I'm Bronwyn Edwards. I'm from Roses in the Ocean. So we are involved in the co-design process, so really pleased to be here with you today. And I'll just hand over to Carrie.
Hi everyone, I'm Carrie and I'm doing some of the facilitation with Roses in the Ocean. I'm also a lived experience member of the Illawarra Shoalhaven Suicide Prevention Collaborative, and it's great to be here. So we'd just like to begin by acknowledging the Dharawal people of the Illawarra Shoalhaven region and to pay our respects to elders past, present and emerging, and to also acknowledge any Aboriginal or Torres Strait Islander people who may be watching this webinar and participating in the co-design process. And I guess also to really acknowledge what Indigenous communities can teach us about being with people in distress in ways that really promote healing and recovery. And we'd also like to acknowledge people with lived experience and the really uniquely valuable expertise that they bring to these co-design processes to improve support for people impacted by suicide, and also to acknowledge the uniquely valuable lives that we've lost to suicide and to people who are struggling today, and to remember that that is the reason that we're doing this process, that we're developing safe spaces all over the country to provide non-clinical compassionate support for people like that.
Absolutely, thanks Carrie. All right, so let's just provide some context because we're, you know, really working our way through this co-design process now. So for those of you who may not have been part of the processes yet, if you've just joined us, welcome, thank you so much. These webinars and feedback loops are a great opportunity to get really out much more broadly into community. So to bring you up to speed, we have, there's been an orientation webinar and an information pack circulated. Those resources can be found on the Illawarra Shoalhaven Suicide Prevention Collaborative website. You'll also find there the New South Wales Ministry of Health guidance documents. They've recently been updated, so by all means go back in and have a look at those. So once we actually released our expressions of interest, we've had people join us from both a lived experience perspective and from a variety of health professionals perspectives, which has been great. We've run a series of small focus conversations and then followed by an all of group lived experience co-design session and then feedback loops at that point, which hopefully some of you have participated in. We then collated all that information. That was then fed through to a health professionals co-design session. And each time it's that, okay, now we've learned this, what do we need to discuss now? What else do we need to unpack and explore? Following the health professionals session just last week, we've now drilled that down yet again, and we are here at this feedback loop that you can see in the middle of this diagram essentially. So today the purpose is to gather broader insight regarding the progress that's been made during the health professional co-design session. So there's been discussions there, and there's some things that have fallen out of that we need to be bringing to you in this feedback loop, and to gather prospective information to fast track the conversation. So there's some things that we're going to ask you in the survey that you will have access to through the collaborative website after this webinar that will actually start to gather your thoughts on a variety of other areas that will then condense all that down, and we'll take that to the combined co-design session that will follow. So that's where we're at. The co-designing of the, sorry, I've just lost my track then. So yes, here, let me just summarise in terms of the feedback loop 2, we're presenting what we know so far from everything, all of those steps that I've just discussed with you, outlined there. So on the left-hand side, you'll see there, agreed through alignment. So essentially what we've been looking at, okay, of all the different views from the Ministry of Health, from lived experience people, from the health professionals, what are the components that are already aligned? And out of that comes the values. So what will the safe space hold itself to? Outward connections and partnerships. So everyone's very aligned around where the safe space will connect people to, when and why. And the physical environment and accessibility. So what does it look and feel like? How do people access it? How do we make it an accessible place for everybody? Throughout the health professionals co-design session, we then wanted to have a look at some of the things where there may not have been complete alignment and there were areas that needed further discussion. Those topics were the location of the safe space. So where will the actual safe space be physically established? Connection pathways into the safe space and how will people in the community access it? And the staffing, so who actually delivers the support at the safe space. So these are things that obviously have been discussed right from the beginning, but there were areas where we needed to unpack it a bit more. And so we'll show you the results of those conversations soon. And then there's still some areas to be discussed. And this is where we're going to start touching on in the feedback loop 2 survey questions that we'll ask you to complete for us. And that are areas around the service model. So what support will people actually receive at the safe space? In terms of reporting, how will we know that it's meeting community needs? Communication and engagement, how will we communicate about safe spaces to the broad community? So how do we make sure that people know about it and what are we going to tell them? And then the governance, who will actually be involved in the governance aspects of the safe space?
Okay, thanks, Bronnie. We're just going to talk you through what's been agreed on so far. So where there's really good alignment between the New South Wales Ministry of Health guidance documents, which, as Bronnie said, you can find the latest version on the collaborative website, with lived experience participants and also with health professionals. And we've broadly themed them in terms of, sorry, if you can just go back, Bronnie, I was just going to,
sorry.
Let's see, values, outward connections and partnerships, physical environment and accessibility, and also workforce development and support. So we'll just go through each of those now. So values to inform the model. There was really strong alliance between the guidance documents produced by the Ministry of Health, which have come out of forums that I think were held towards the end of last year and early this year. So these are values that are very familiar to people now throughout the co-design of the safe space. So welcoming, compassionate, hopeful, holistic, empowerment, and human connection, collaboration. And through the lived experience co-design process, so that early part of this process, a lot of those values you can see are pulled through there. And so we feel like there's already strong alignment there, and while they'll need to be refined, there's sort of good in principle agreement. So all of those values that you see there that have come out, that lovely big group of values through the co-design, the lived experience co-design process, will be boiled down to some core values that will inform the model that's produced through this process. Thanks, Bronnie. So outward connections and partnerships. And if you see in the guidance documents, it talks about the idea of people being able to access information and to be warmly connected to a broad range of community-based health and social services. And that was really reflected in discussions, both in the lived experience part of the co-design and also through the health professionals session as well. So just the idea that collaboration and integration with the health system is important, but that is driven and led by the people, the guests of the safe space, and then the health professionals also reflected that idea of building relationships with the safe space and with other services, and just the need to understand how those things will be coordinated and integrated. Thanks, Bronnie.
I'll just jump in, Carrie, just for one thing, because I've some of the language that's used, for example, just in that top point there where there's a skilled workforce to enable escalation when required. The language, we have had discussions around language, and there's really good consensus right across the board around not using terms like escalation. It's simply there because that's how it came through the co-design process, but there is agreement around that it's more about supporting people to make those connections as they are wanting them. So I just didn't want people to be concerned about that language, but we're being true to how it's actually come down to that point, just through that process at the moment.
Thanks, Brenny. And then physical environment and accessibility. So there's one of the key things that the guidance document says is that there's no requirement for people to present to an emergency department prior to accessing the service. So I think when this process began and when we first started to think about a safe space as an alternative to ED, sometimes there can be confusion about what that means, an alternative, that maybe it means that people, when they rock up to ED, are assessed and then redirected, but it actually means that these spaces are genuine alternatives, that they're places that people can access themselves, can perhaps ring up for themselves or be supported by their natural supports to access services. And you can see there, and this is very aligned right across the board, that a safe space is a welcoming, safe and calm environment, and this includes cultural, spiritual and emotional safety, and that it operates according to trauma-informed principles. And then that's pulled through the lived experience. Participants really underlined the idea that it's a safe and welcoming space, as well as the fact that it's doesn't look like an ED inside, that it's aesthetically pleasing and that it's functional and a warm. And I think that means literally and metaphorically. And then also, that was also very much aligned with what came out of the health professional sessions, that it's a safe, secure place where people are welcomed, and also that it was said that people need to be met where they're at. And I think that means literally and metaphorically too, that people are greeted like guests, but also that they're met where they're at in terms of where they're at in their lives. So it was also brought up that it would be ideal if that was open 24 hours, but you can see that's out of scope. And that's just about resources, about the fact that there's limited resources for these things. And perhaps one day in an ideal world that these will be available. So all of this sort of information that's out of scope for this co-design process is still captured and fed back, so that as an iterative process down the track, these sort of things can be considered. Thanks, Brenny. There's also broadly the theme of workforce development and support, and there was real alignment here about the need. The ministry really, really understands the need that to have an effective and sustainable suicide prevention specific peer workforce that is really of high quality, that there needs to be support for ongoing training and supervision and individual co-reflection and group co-reflection, and those opportunities that are really important for peer workers to be supported in the jobs that they do, and to also to be recognised as professionals. And you can see that also came out very strongly in the lived experience co-design sessions, that they want to see a highly capable lived experience of suicide peer workforce, and that those, in order to have that those people require a lot of support, and including sort of ongoing mentoring and group reflection opportunities. And then that was very much aligned with what came out of the health professionals session as well, the idea of ongoing training and ongoing mentoring for peer workers. Yeah, thanks, Bronnie.
Lovely. Okay, so then we move on to the health professional co-design session. So this was the first time that all the health professionals came together after their focus groups, and we were looking at the location of the safe space, connection pathways to the safe space, and staffing. So there was some divergence between the Ministry of Health guidance document, lived experience people and health professionals prior to the session. but we have in principle agreement reached by the end of the co-design session, which was great. What you'll see in the following slides is an expansion, I guess, of the colour coding. So where all the slides that Carrie's just taken you through, everything was green, showing full alignment. So we used a traffic light system for things that were in full alignment were green. Those that were issues that we needed or areas that we needed to further discuss were coded in the orange, and then anything that was out of scope in terms of the Ministry of Health's guidance document was in the red, as you saw there before with the 24 hours. So when we talked about the location of the space, so there was definitely from a lived experience perspective that preference for it to be located off hospital grounds, but within walking distance, centrally located, easy and safe to access. You know, the guidance document says that it can be located on or off hospital grounds. And so what we then did was we took that, opened that up to discussion, and with regards to the on or off hospital grounds, there was consensus reached for the safe space to be off hospital grounds, but located nearby. So definitely an acknowledgement that it was going to be preferable to be able to get to the hospital if people wanted to go, and also if people were going to come from the ED, that it was accessible quite easily. Health professionals acknowledge the wishes of lived experience participants and really genuinely want to meet their needs. From a physical location, we just had a little bit of time at the end of that session, and we posed the question about where, like where in the region would people think about. And there were a couple of suggestions suggested in terms of Wollongong or Nowra. And I think this is actually something that we're bringing forward into the survey questions as well. And I think it's important to start thinking about what's more important, and we will need to do some prioritising in the last sort of round of this, because is it more important to have the model that you're really wanting that comes out of the co-design process, or the location? So for example, it may not be possible to find the physical environment that everyone's envisaging in one of those locations. So it's going to be a little bit of a give and take when you're coming to really decide upon the location as to do you compromise part of the physical environment that you're looking for to have it in the area that you think you need it in, or would you rather it you know, in that area, and do you give away some of the components of you know, the blue sky and what you'd like it to feel like? So anyway, pros and cons for both locations were raised, and an agreement that really a really good strong argument could be made to locate the safe space at either location. So this is absolutely open for conversation though through the survey process, because some of you may have other ideas as well. Okay, then we went into the connection pathways to the safe space. So you can see there was you know, areas that were absolutely still up for discussion, and from the health professionals' perspective, they were really wanting to understand and discuss things around addressing risk and duty of care, accountability and what have you, guidelines for referral criteria, and you know, how the safe space would actually work with and support people with presenting with various needs. From the Ministry of Health guidance document, it was they're talking very strongly about there's no requirement to present to ED prior to accessing the safe space, that there's no expectation of a clinical referral pathway from the ED to the safe space, and that the guests attending the safe space are not required to undertake any assessments and meet eligibility criteria, and that the safe space is actually promoted in the local community so that people are really aware that it's there as a genuine alternative. So after discussions, we discussed that there was broad support for no expectation of a clinical referral or attendance at the ED prior to accessing the safe space. The health professionals acknowledge that it does present some challenges with how the system is currently set up. Not that they're insurmountable, but there'll just be some work and some discussions to carry on with. And there was consensus that safe space isn't being developed to change how the LHD operates. You know, you are creating a new a new space, a new type of service for people to access. So there's still some more progress that we need to make and some further discussion to be had around transfer of care protocols, and education of LHD emergency department staff will be required, both regarding what the safe space offers, but also how the staff within ED meet the LHD obligations that they have. So there was a good recognition that you know, there are certain policies and protocols within the ED environment and other services, and it's not the safe space's role to change how they have to do their work, but how do we make it such that that makes it accessible for them to actually support someone to enter a safe space. So the safe space to be offered as a genuine support option, and that, you know, there will need to be good, strong relationships between the safe space and the LHD and the ED particularly. So they're just some areas that we will continue to discuss and unpack as we go. When we came to staffing, the Ministry of Health guidance document states that it will be a non-clinical suicide prevention peer workforce, that the service is staffed by suicide prevention peer workers with a lived experience of suicidal crisis and recovery, and that recruitment and training of the SP peer workforce will be undertaken in line with the New South Wales Ministry of Health Suicide Prevention Peer Workforce Guideline document. I'm pretty sure that that is also up on the collaborative website, and if it's not, we'll make sure it goes up there for you. So the areas, as you can see, if you follow the traffic light situation there, there's a red one that was out of scope, anticipating people will need a clinician on staff to feel comfortable in referring from ED. So with the Ministry of Health guidance document, where it very clearly articulates that there's a non-clinical workforce, and that it's staffed by suicide prevention peer workers, that then became out of scope. There was a good alignment around the health professionals, very supportive of having highly capable peer workers and for it to be less clinical and a more relaxed space. But we did need to talk more about, there were still some views held around potentially a mix of clinicians and peer workers. So we wanted to understand that some more. So where we landed in the staffing space after our discussions was that there was acknowledgement of the genuine requirement for all staff to have lived experience of suicide, a preference for peer workers, so no clinical staff required, and that it may be worth identifying positions to ensure that there's a really good mix of cultures, sexuality, gender to meet local needs, so that when recruiting the suicide prevention peer workers, we make sure that there's a really nice diversity of peer workers that are available to support people who may come to the safe space. The other thing that was brought up, which was interesting too, that if necessary, to bring, if it's decided that external people could come to the safe space to co-facilitate groups, for example, with a lived experience suicide prevention peer, that they would be from an allied health background. All right, over to you, Karen.
So we're just going to take you through, I think there's already some great questions and comments coming through, so we won't take too long here, because a lot of these are questions that are captured in the survey for feedback loop too. But this is really what remains to be discussed and determined. Bronnie's already raised some of this stuff, and we've sort of broadly themed it in terms of service model, information gathering and reporting, external communication, and then also governance issues. Thanks. Bronnie. Thanks. Okay, so service model, and you'll see using the traffic light system again that there's a lot of alignment here, that all the alignment between the Ministry of Health guidance and then the lived experience participants, co-design sessions, what came out of there. So there's, again, it underlines the fact that clinical services are not provided. What is delivered in the service must be non-clinical. Lived experience participants strongly emphasise the need for it to be a non-clinical support. And then also, again, this idea of collaboration with other services, with the health system, but also with a broad range of social and community services, and that idea of being able to be warmly connected to them. And also there's in the ministry guidance document, there's a recognition that family and friends are involved, so that collaborative care approach where possible, but always person-led, so in alignment with the wishes of the guest accessing the safe space. And then if we look across the health professional sessions, what came out of that was that there needs to be a clearer understanding of what the service offers and also a clear purpose. So in terms of offerings, there was suggestions, as Bronnie had said before, the idea that there might be groups might be facilitated in there, and then also we need to think about what's the clear purpose. So one of the things that is still up for discussion is who is the cohort that this support is aimed at. Is it, first of all, things like, is there an age range? Is it 18 plus? And also, is the support, is the primary purpose of the support the people in crisis, or is it also a support there for people who identify as carers as well? And then you'll also see in the red, so these are the things that are out of scope, and these are about really other services that came out of the health professionals co-design session, some of the services that they'd suggested for the region, so a hub with suicide prevention clinicians, also a dedicated crisis centre, and those things, while they're out of scope for this co-design process, there are other co-design initiatives taking place, and we certainly always are committed to capturing this information and feeding it back to the LHD and to the ministry and back into those other co-design initiatives to make sure that this information isn't lost. Thanks, Bronnie. And so these are just some of the questions. So these are the questions that you'll be asked to respond to in the survey, and then also these are some of the questions that then will be up for final discussions in the combined session on the 10th. So I've raised, I think, some of these before, but also just, yeah, what's the minimum service response that all safe space guests will receive on accessing the safe space? So that's the idea of whether there'll be groups, are people just able to just drop in, or will it be something where there'll be more structured activities or semi-structured activities as well? And then also, how will the safe space address the needs of particular priority populations? Thanks, Bronnie. And then this theme is around information gathering and reporting. So if you look at the guidance documents, the ministry is very clear about the fact that outcome reporting, unlike in traditional services, it needs to be very non-intrusive and not present a barrier to people accessing the space. And as a result of thinking about that, the lived experience participants really came up with some cool ways of thinking about how to collect information with guests using things other than standardised assessment tools. So the idea of people being able to author their own stories in recognition of the fact that one of the barriers to access and one of the very exhausting parts of being in distress and accessing services is the need to have to tell your story over and over and over again. And so with the health professionals, that is still in need for further discussion. So this is some of the stuff we'll be asking for feedback on, and then making some final determinations in the combined session. So again, the questions are things like, what are the indicators of guest experience? So how do we collect meaningful data that tells us about whether the safe space is meeting the needs and wants of the people that it's set up to support, and then just stuff around those traditional reporting metrics. To what extent will the safe space be required to collect data around numbers of people accessing the service, incidents, those sort of things. Thanks, Bronnie. And then external communication. So just some of the questions are around how emergency department staff, for example, so clinical staff will be supported with information and education about the service, and perhaps even is there going to be a peer worker to be part of that process and be part of the sort of education process? How will the safe space be promoted in the community? And then what sort of partnerships will support local connections for guests. So that recognising that there's a very broad range of reasons why people may be in distress, and so the idea that there needs to be some meaningful connections for a broad range of community services and other supports. Thanks, Bronnie.
Alrighty. So now on the topic of governance, as I mentioned a while back, I've actually got a meeting this afternoon with David Alcorn from the LHD and Alison from the PHN, just to sort of further unpack and understand what that's actually looking like. The Ministry of Health guidance document states that clear governance and reporting lines within the health service are required to provide oversight and support. A clinical governance structure which provides a clear process to actively support suicide prevention peer workers when and how additional clinical supports may be needed. Ongoing opportunities for lived experience involvement. So, and being very transparent about all policies and procedures. Definitely from a lived experience perspective, looking for ongoing involvement in shaping the design of the safe space, so that, you know, really embedding into the service that there's this constant iterative process that goes on, and that ideally people who've actually utilised the safe space will then be able to feed back into that to continually improve it. And being aware of protocols and procedures and ensuring that there's full transparency, that nothing is a secret. So this area around governance, we still do need to unpack a bit further, and we will do that in the co-design session 3 following our meeting with the LHD and PHN as well, just to get a clearer understanding of what any particular hard boundaries are, and then to, you know, collaboratively work through those. So yes, so there will be, you know, questions around what will the operational governance look like for the safe space, and what will the clinical governance look like. But I think what is important there, if I just slip back to that other slide, was this second point from the guidance document around a clinical governance structure which provides a clear process to actively support the peer workers when and how. So it's saying, you know, if there is a need, and if the suicide prevention peer workers need some additional support, then it is available for them when working alongside a guest of the safe space to work out what, you know, what they need to keep themselves safe. So to be advised. So next steps from here. The links to the webinar and the survey will be available by this afternoon on the Illawarra Shoalhaven Suicide Prevention Collaborative website. We would ask you to please go to that survey, respond to it by midnight on June the 7th, which is Sunday night. Co-design session number 3 is on June the 10th. So we just need to give ourselves time to review everything that everybody shares with us in that survey. And then we will have a mixed group of people, which will have half of the lived experience group and half of the health professionals that will come together. Normally we'd have you all together, but because we're online, we're just limited with numbers. We will be in touch with you soon about that further. So we might actually stop sharing screen and just come back to Carrie and I, and then we'll have a look at our chat and see what questions we're able to answer. Have you seen any there, Carrie? Because I haven't been able to see it while I've had my shared.
There's one from Bruce, who's a lived experience participant. Will the operating hours be informed / determined by data about the times people are currently presenting to ED? i.e. will the safe space only be open at times likely to reduce presentations to ED? That's an excellent question, actually. Do you have any advice around that, Bronnie? My understanding is that it's going to be, that hours will be determined by what people in the co-design process representing the what the needs and wants are of the communities, and that it's responsive to local need rather than organisational need. Is that right?
Yes, look, that's my understanding. I mean, the Ministry of Health guidance document certainly states that it is to be open after hours. it's not saying that it's only open after hours, but they are wanting some after hours availability of the service. But this is something that definitely will go into co-design session 3. And look, if any of you have particular thoughts about that, now there's lots of open text boxes in the survey. So please, if you've got any ideas, you can put that through. I think it's about looking and seeing what community needs are and what they want. There's no reason to not grab information from all sources, but ideally it will be guided by the co-design outputs. So Bruce, there is just mentioning a compromised location of Shoalhaven had been suggested, but you know, it may not be viable because of poor accessibility by public transport, especially at night. And I think in the health professional session as well, there was talk about it not necessarily being deemed a safe sort of place to be going for some people as well.
And then Jocelyn's said, if no clinical staff will be part of this model, will there be a chance to have a similar model set up for alternative to ED? I'm just wondering if what Jocelyn's saying, and she might be able to clarify, is the idea that there will be an alternative to ED within the hospital that's more like a safe haven cafe perhaps?
Oh, can you still hear? If you can hear me, just hold on. We've lost all power here in my office.